It's my pleasure to introduce Dr. Marino, who I've known for a long time. She's, certainly I've got a very high regard for her. She did her undergraduate at St. Joseph's. She did her medical school at the Philadelphia College of Osteopathic Medicine. She did her fellowship at UPenn with someone named Dr. Curtis Slipman. And she's a board-certified physical medicine and rehabilitation doctor. Sometimes I call it physiatrist. And she specializes in the spine, both neck and back.
I'm going to be talking about understanding spinal injections for pain management. This isn't aimed to be completely comprehensive of all the things that exist out there to help people, but really just to give you an idea of what's out there, what it does, what it is, and how it can help you. I'm going to do this in 3 parts, this talk. The first part is anatomy. We're going to go over just so that everybody has an idea of what the spine looks like, the complexity of it, and why it can sometimes be so frustrating that we can't figure out an answer for some of our painful problems. Then we're going to go over the pain generators, or the common pain generators in the spine. And then we're going to talk about the treatment with interventional techniques. That means injections. So when I'm talking about this does not rule out physical therapy as an option. Typically, people who are coming for injections are those that have not done well with physical therapy, or not getting to where they want to with physical therapy. Or sometimes people are in too much pain to do physical therapy, and so sometimes doing some of these interventions is helpful beforehand. So this is 3 different views of the entire spine. The spine starts just at the base of our head and goes all the way down to our tailbone, called the coccyx. There are 5 different segments of the back, or the spine, I should say, from the bottom of our head to the top of our shoulders. That's called the cervical spine, or the neck. In between there is the next segment down is the thoracic spine, and that's where all of the ribs are attached. The next segment is called the lumbar spine, and that's we all know as our low back. Then comes the sacrum. The sacrum is this area of bone down here, and it looks a little bit different because each of these bones are fused together in the sacrum, so it kind of looks like a horseshoe crab. And then the next segment down here is called the coccyx. We're going to, in this lecture, talk mostly about the lumbar and the cervical spine. Certainly you can have problems with the coccyx, the sacrum, and the thoracic spine, but we're not going to focus on that today. Okay, so we're going to look at the lumbar spine a little bit more closely right now. The lumbar spine has 5 bones in it. The bones in the back are called the lumbar vertebrae. Right here we see the L1 vertebrae, L2, L3, 4, 5, and then the sacrum begins. This top segment is called the S1. In between the bones are the discs. The discs are named for the bones that they are in between. So this is the L1-2 disc, L2-3, L3-4, 4-5, 5-1. The vertebrae is this entire bone. The front part of the vertebrae right here is called the vertebral body. In here is where the nerves travel. And in that canal is called the central spinal canal. The nerves then come out of the spinal canal through this hole. These holes are called the neuroforamen, and that allows the nerves to come out and then travel down our legs or travel down our arms. Behind where these nerves come out, there's a couple of structures which we'll talk about. Something called the facet joints, F-A-C-E-T, facet joints, which are these little knuckle-like joints in the back and in the neck, and they can be a source of pain. And then we're going to talk about just this spinous process. And if you feel your back, the bones that you're feeling in your back, what you're feeling is that spinous process. So that's the lumbar spine. Everybody likes to look at an x-ray. So this is an x-ray of the lumbar spine. What I like to point out to people is that, is this curve normal? People always ask me, is that normal? Is it supposed to be curved like that? And yes, it is. The lumbar spine, this is a picture of it from the side now. So I don't know if I have a pointer, but this is the front of the spine, this is the back, these are the bones. So again, L5 vertebrae, L4, 3, 2, 1. In between here are the discs. You cannot see what the discs are doing on x-ray. Discs are soft tissue. X-ray only shows us bone. But you can tell if the space in between the bones you can tell whether the space in between the bones is adequate. And this looks like a normal lumbar spine x-ray. The space in between the bones looks pretty good. And then this curvature, which I talked a little bit about before, is normal. It's called the lumbar lordosis. That is different from a scoliosis. Scoliosis is when you're looking at somebody from the back and you see an S-shaped curve. Totally different. This is normal. Scoliosis is not normal. So now we're moving on to the cervical spine. So the cervical spine is made up of 7 bones. We call those the cervical vertebrae. Again, see one up at the top here, 2, 3, 4, 5, 6, and 7. Again, in between these bones are the discs, and again, the discs are named for the bones that they are in between. So up at the top, we have the C2-3 disc. There is no disc between C1 and C2. So we start here at C2 and C3. C3, 4, 4, 5, 5, 6, and 6, 7. Again, this is where the spinal cord travels, right in here. Now you can't see it, it's behind the bone, but that's where the spinal cord travels. And off of the spinal cord comes the nerves, and the nerves have to come out of the neck somehow, and they come out of these holes called the neuroforamen. Behind that are these little joints in the neck called facet joints. This right here is a facet joint, and you have that at every level. In the back of that, again, is the spinous processes, and those are what you feel when you feel the bones in the back of your neck. Here's an x-ray. This is an x-ray of the cervical spine. This is a relatively normal x-ray. Again, you have the 7 bones. Here's C1, 2, 3, 4, 5, 6, and 7. In between the bones are the discs. This looks like normal disc height here at each level. These are those little knuckle-like joints that I was telling you about, the cervical facet joints. And these look relatively normal. Again, you can have a normal curvature in the neck called the lordosis. There should be a little bit of a cervical lordosis. Sometimes people will have a lot of muscle strain or sprain in their neck or spasm, and you can get a straightening of the curve of the neck. And on our x-ray report, you'll see straightening of the normal cervical lordosis. Sounds very fancy. It just means that the neck looks straight. So I said to you that those nerves have to come out of the neck and out of the low back, and they have to go somewhere. Where do they go? So this picture shows us that in the neck, all of these nerves come out, and they form this big group of nerves that sits right here underneath the rib, or above the rib cage, called the brachial plexus. That brachial plexus then goes down our arm and gives sensation and muscle strength to everything in our arm. Same thing in the low back. We have, sorry about that. We have the nerves in the low back that come out. They form the lumbar plexus. Plexus is just a fancy word for a group of nerves. Those nerves then come together and go down our legs. This here is a picture of the sciatic nerve. We've all heard about the sciatic nerve as a nerve that can create pain down our leg, and this is it. So that's just an understanding of how all of these nerves come off the spinal cord and then go down our arms and legs to give us our motor strength and our sensation. So switching over a little bit to what the disc looks like, I have some samples of our models of the spine here, which you guys can come and take a look at after. But this is a side view of the spine, and this is what we call an axial view. Okay, and that's what we're looking at in this particular picture. We're looking at what we call an axial view, or if somebody were laying down here, that's what we're looking at. And we're looking at the disc here, and the normal anatomy of the disc is these concentric collagen rings, which we call the annular fibrosus, and inside is a squishy donut center called the nucleus pulposus. And that nucleus pulposus can be very inflammatory if it's not contained within the disc. And that can lead to a lot of problems like sciatic pain, pain within the back, and we'll talk a little bit about that in a few slides. So that's really the normal disc anatomy. Just for completeness sake, I'm going to show you how all the muscles come together. I don't want you to actually understand each of these muscles, but I just want to give an idea of the complexity of the back. The spine doesn't exist in isolation. The muscles are there to help support the spine. And there's the deep layer, and there's a superficial layer. The deep layer here doesn't really look yet like a human, and now all of a sudden we put all the muscles on and it starts to look like the normal physique of a human. Again, just to understand that the complexity of all the layers of the muscles, the bones, the nerves, the discs that are involved in the spine. So what are the pain generators? Anybody feel like that here? So we're going to talk about the different pain generators. Okay, so muscles. Muscles can cause pain. We're not going to go into all the muscles again in detail, but just to know that they are a source of pain. Physical therapy is a great thing to help muscular pain. Physical therapy is really a great thing to help a lot of these different sources of pain. And usually that's the first line of defense. And most people do well with it. So we start doing this, talking about this other stuff when you need a little something else. So the discs can cause pain, nerves, joints, bone, and then of course non-spinal causes. So that means like something in the abdomen, kidney stones can sometimes refer pain to the back. We're not going to get into great detail about the non-spinal causes, but just need to put it up there as a potential source of pain. So disc pathology. This is a great slide. It shows all the different kinds of problems that exist in the discs. And unfortunately, these problems don't exist in isolation. Sometimes the disc just has some thinning. Sometimes it's got some thinning and a herniation, or sometimes it has a bulge with a herniation on top of it. We're going to go through what all of those different things look like and what they mean. So this at the top is a normal disc. It means it's got a good disc height. It's nice and plump and juicy. The annular rings that I showed you on the disc are all intact, and everything is working normally. The discs serve to be the cushioners or the shock absorbers of our spine. That's the purpose of them. Here's a degenerative disc where you see a little bit of a crack in the disc here. It's a little bit less in height. It's not as plump and juicy as it should be in a 25-year-old. And we have a bulging disc. And a bulging disc basically means that a portion of the disc extends beyond the back of the bone, usually into the canal where the nerves travel, but can extend at anywhere around the circumference of the disc. So anywhere around here you can have a portion of it bulging. We only care if it bulges backwards because that's where the nerves are. Now we have a herniated disc. And I will get into a little bit what's the difference between a herniated disc, what's a bulging disc. But this is also defined as something that protrudes past the back of the bone, or protrudes past the level of the bone. Then we have a thinning disc. A thinning disc is really just another name for a degenerative disc. So I'm not sure why they put that on here, but in any case, I'll mention it. And then we talk about disc degeneration with osteophyte formation. What does that mean? That means that the disc is no longer of normal height. You have some degenerative changes, and then what happens is the bone around the disc starts lipping out and causing almost like a ledge. And I have some bones up here that show the difference. So this is the degenerative disc. This is a normal disc, and you can come up and take a look at that. You can see how the ledge is starting to form here.
In the first degenerated disc, if there's a split in the disc, how come the gel within it has not oozed out, but still will go to a bulging disc before it begins to ooze out?
So actually that's a good, this is not a progression of what happens.
Oh, I see.
This is just different types of just problems with the disc.
Because if there's a split like that, the gel inside would come out, no?
So that's why I wanted to show you all the different layers of the.
Oh, okay.
So if some of those layers are problematic, but not all of them, that jelly center may not come out. So this is an annular tear or a fissure. A tear makes it sound like it's something traumatic that happened, but it doesn't necessarily have to happen from a trauma. It can just be from wear and tear, life. But essentially this is that jelly donut center, the nucleus pulposus. Here are these rings that go around. So you can see it doesn't quite get to the end of the disc, so it's not going to get the jelly donut center out of there. The problem is that these fissures, this sort of center, this jelly donut center, can leak into these fissures and can cause this inflammatory response that is unbelievable. If you have this kind of pain, you think, I must be dying, something is wrong. And what's wrong is really not that bad, it just feels horrendous. Okay, so a herniated disc. Again, we talked about a herniated disc is when the disc and the inside disc material pooches out past the back of the bone and comes into the spinal canal where the nerves travel. This can happen in the cervical spine, the thoracic spine, the lumbar spine. Most common sites of disc herniation is in the cervical spine, particularly at C6-7, and in the lumbar spine at L5-S1 and L4-5, the two lower levels. Okay? So what happens when this disc is herniated? When this disc is herniated, it pushes up against the nerve and causes pain. The typical pain from a herniated disc is pain radiating into the arm or pain radiating into the leg. And the leg pain or the arm pain is actually much worse than the neck pain. Now that's not always the case, but that's what the textbooks tell you, that the leg pain or the arm pain is worse. And it will typically radiate in a pattern significant to the nerve that it's pushing on. So for example, the L5 nerve root, which comes out between the L5 and the S1 vertebrae, that will typically radiate pain down the outside of the thigh, the outside of the calf, and can go all the way to the tip of the toe, the big toe, typically. It can also cause weakness, can cause numbness, and we get a little bit more concerned when there's weakness. When there's just pain, you know, we worry about it because it's uncomfortable, but when we start getting weakness or sometimes even bowel or bladder problems that can occur with this, that's when we start saying, you know, maybe you need to get to a surgeon. Everything you're doing so far is not really the right thing. We need to get a little more aggressive. So that's a herniated disc. Okay, so I said I would describe to you what's the difference between a bulge or a herniation. So here's the black is the bone or the vertebrae. Again, we're looking at it in this particular orientation. So the person is laying down. So the bone is here. That's what we're looking at. So the black is the bone. And if it's a bulge, the definition of a bulge is that it pooches out over the bone in more than 50% of the circumference of the bone. So here it's the whole way around. A protrusion is defined as pooching out less than 50% of the circumference of, or past the bone. Does that make sense? Mm-hmm. And it's a little bit more pinpoint. Here's some other descriptions of protrusions or herniation. A protrusion or herniation are the same thing. They're interchangeable. This is a large protrusion. Again, still less than 50% of the circumference. Here's an extrusion, and the difference is that the base of it is a little bit smaller than the base of this. And then you can get a free fragment where this can actually break off and go into the spinal canal and still push on nerves. This actually has the best prognosis because your body will reabsorb that fragment over time. So that's the difference between a bulge and a herniation. This is just an MRI showing a herniated disc because everybody likes to look at films. This is a picture of an MRI. The patient is being looked at through the side. This is the belly. This is the back. These are the bones and the discs. This is the canal where the nerves travel. This is the low back that we're looking at, the lumbar spine. This all looks terrific. And then we get down to here and we see, oh, what's this schmutz in here? And that's the disc that has pooched out into the canal and is now pushing on the nerves. Now, what I always like to tell people is, I can't tell you whether or not this person's having pain. We don't treat MRIs, we treat humans. We use the MRIs to correlate what we find on the physical exam and what the patient tells us, but I can't tell you whether or not this person's having pain. If I were gonna guess where this person was having pain, I would look at this picture. In this picture, the person's laying down, their feet are out towards me, their head's into the board, their belly is up here, this is their back, and this right here is the central canal where the nerves travel. So we're looking at it like this again, and this is the central canal that we're looking at. And you can see here, this is the herniated disc, and it's pushing against probably the S1 nerve root, which will typically give pain in the butt, down the back of the thigh, down the back of the calf, and onto the bottom of the foot. So herniated discs in the neck can do the same thing. If you have a herniated disc in the neck, things that we worry about is the spinal cord have enough room to live and do what it needs to do. Sometimes you can have some narrowing in the canal where the spinal cord travels that it's so severe that you can start getting problems with coordination of the hands, balance problems, bowel and bladder dysfunction. That can also happen with a herniated disc in the low back. Either way, if that stuff starts to happen, that's a surgical emergency. Surgical emergency for the low back is something called cauda equina syndrome. And what does that mean? All these nerves in here, when you look at a cadaver, look like a horse's tail. Cauda, tail, equina, horse, so horse's tail. And if you start getting symptoms of numbness and tingling into the groin region, meaning anywhere that you would sit on the saddle of a horse, if that were to become numb, that's usually associated with weakness and pain down the legs. Go right to the emergency room. You need to get that decompressed right away. That doesn't happen very often, but when it does, it needs to be treated ASAP. Okay, so another problem in the spine that can pinch nerves is spinal stenosis. Spinal stenosis is a narrowing of the central canal. And it's usually caused not by a herniated disc, although that can cause spinal stenosis. In this picture, we see that the ligament that runs back here is getting a little bit bulky. The ligament that runs over here is getting a little bit bulky. We probably have a little extra bone formation over here. And now the canal where the nerves travel is too small. Instead of looking like this, it starts to look like this. And that typically happens in 60 and 70-year-old folks and older. And the common symptoms that people complain about are pain with standing and walking. And they tell me, when I go to the grocery store, I like to lean on the cart. It really feels good. I can walk longer. A lot of people will say that. And that's even what they say in the textbooks. And we'll talk about whether or not injections will help for that as well. So joint pathology. We're going to talk about the different joints that can cause back pain. So facet joint pain. Facet joints are a common cause of pain in the back and the neck. They're little knuckle-like joints in the back of the spine. And you guys can come and take a look at this a little later, but essentially this little joint right here, this little joint right here, on either side of the spine, from the neck all the way down to the sacrum. And they can cause pain. The reason for them is they help us, it's a mobile structure, so it allows us to bend and turn and twist, and it helps to support the spine. Typically the kind of pain that you get from facet joints is really just in the neck and in the back. Sometimes it can radiate a little bit into the top of the butt or sometimes into the top of the shoulder, but for the most part it stays in the back or in the neck, and we call that axial pain, and it's just in the axis of the spine. We're going to talk a little bit how to diagnose facet joint problems. There's really no way to say for sure if it's a facet joint problem on just a physical examination, so we'll talk about how we diagnose that. Sacroiliac joints. Sacroiliac joints are joints in the pelvis that can also cause discomfort. So here's the lumbar spine. This bone right here is called the ilium, and that's these bones right here where your grandkids or your kids sit. And then this is the sacrum right here. In between that is the sacroiliac joint. And the sacroiliac joint can cause pain either from trauma, from degeneration, an inflammatory process, and that can be a source of back pain. Typical pain from an SI joint is pain sort of right over to the side of the back, not really in the center. People will come in and say, I have pain right here, and that's called the Fortin finger test. Some guy, Dr. Fortin, said, when people come and point right there, it's the SI joint. And that's not always the case, but you know, that's what he said. The SI joint can also radiate pain into the leg in any distribution. It can go down the back, it can go down the front, it can radiate into the groin. So again, it's one of these structures that you don't know whether or not it's causing pain until you start doing test injections for it, and we'll talk about that. I don't want to leave out hips. Hips can sometimes, an arthritic hip can sometimes refer pain to the back. Typical hip pain will give you pain into the groin. But sometimes we get fooled. People will have back or buttock pain for years, and then we find out, oh gosh, it was the hip all along. And replace it, and everybody's happy. All right, so bone pathology. Something called a compression fracture. Compression fracture is a fracture of the front part of the bone or the vertebral body. And basically what happens with that bone is it's like you squished it, like you took a marshmallow and squished it. This can happen from trauma. It can happen with people who have osteoporosis. Sometimes I have people with osteoporosis who are just walking around and all of a sudden they come in, I didn't do anything, it just hurts. And they have a compression fracture. And then sometimes if there's a tumor in the bone or something like that, that will create a compression fracture as well. This can be diagnosed with X-ray, CAT scan, MRI. If I'm concerned about somebody who has like a cancer history, I will get an MRI to see what the bone looks like inside. You'll be able to tell whether it's just, you know, regular compression fracture or is there a tumor or something there. A pars fracture is a fracture in the back ring of the vertebrae. So I talked about how this is the vertebrae and there's that central canal. That central canal is made up of a ring back here and the vertebral body up here. You can get a fracture back here. And what happens with that fracture is sometimes the bones start to not line up perfectly. So if you have two bones that are sitting up on top of each other like this, with that pars fracture, the top bone can slip forward on the bottom one. And we call that a spondylolisthesis. A pars fracture by itself can cause pain. Spondylolisthesis can also cause pain. You don't necessarily have to have a pars fracture to have a spondylolisthesis. There are other reasons for that, but we won't get into that right now. All right, so now the reason you guys came here is how can these injections help? Okay, so epidural injections. What are epidural injections? Epidural injections are an injection of medication into the epidural space. What's the epidural space? Okay, so here's the spine, this is the front, these are the vertebral bodies, these are the spinous processes, these white right here, in between are the muscles, and this is the spinal cord right here, so we'll say that this is the neck. Can you see that white line right there? That's the dural sac, D-U-R-A-L, dural sac or dura. Stands for tough mother, because it's very thick, and that's the sac that contains the spinal cord and the nerves. So an epidural just outside the dura is an epidural injection. So you can see right here in this picture the needle's going right inside the bone and outside the dura, and there's some fluid being injected. Inside the dura is the spinal fluid, so you don't want to go through the dura, otherwise you start getting some spinal fluid out. Spinal taps, you do want to go through there, but not for an epidural injection. Okay. How can you do an epidural injection? There are a couple of different ways to get medication into the epidural space. There's something called an interlaminar or a translaminar approach. There's a transforaminal approach. There's something called a caudal injection. This is down in the sacrum. There's something called the sacral hiatus, which is just an area in the bone where the needle can get through and enter into the epidural space, and the medication gets flushed up here. Okay, so what medications are getting injected with an epidural injection? You can inject any medication that you want. When women are in labor, an epidural injection, they inject some pain medication called fentanyl, and they usually inject a little bit of lidocaine, which is the numbing medicine that you get at the dentist, and that helps to control the pain for contractions. For people with pain that's radiating down their legs or down their arm, we inject some corticosteroid or a steroid. Steroid's the best anti-inflammatory you can get. We talk about non-steroidal anti-inflammatories like Aleve, Advil, Motrin. This is a steroid. Like I said, it's the best anti-inflammatory that you can get. So if there's an inflammatory response inside the canal where the nerves travel and the nerve is pissed off and inflamed, we're going to put some steroid in there and see if we can quiet things down. We also put in a little bit of lidocaine, the numbing medicine like you get at the dentist, and both of those medicines together can help quiet things down. So people who are good candidates for epidural injections are people who have radiating pain down the arm, radiating pain down the leg. They're not great for back pain. And in fact, some insurance companies have stopped paying for epidurals for back pain because they just don't seem to be effective. It's really for people who have pain radiating down the arm or down the leg from a pinched nerve in the back or the neck. These are some of the questions that I get asked. So what do you expect? An injection is done under X-ray guidance, live X-ray guidance. So I usually tell people you're going to come in, you're going to lay down on your belly, I'm going to clean your back off, cold sterile iodine solution. I'm going to take a picture, I'm going to see exactly where I need to go. 1, 2, 3 pinch, I get the needle in right where it's supposed to be. Once the needle looks like it's in the right spot, I actually put a little bit of contrast dye in under live x-ray to make sure that the medicine's flowing in the right direction. Once everything looks good, then I'll put a little bit of steroid and a little bit of lidocaine in. People will feel better, usually within 24 to 48 hours, they'll start to feel something kick in. I usually say 2 full weeks to feel the full effect. As the medicine's going in, you may feel some pain radiating down in the distribution where you have pain. So sometimes you can feel pain radiating down the arm or radiating down the leg. And then sometimes people can get a little wobbly because that numbing medicine that goes in can numb up the nerves a little bit, and legs can feel like spaghetti noodles for about 20 minutes to an hour afterwards. That is normal. So then the question is, do I sedate or do I not sedate? That is the question. So it's really a personal preference. For people with low back injections, lumbar injections, I give them the option. If you hate needles, you don't want to feel any pain, you're sick of being in pain, you want to go to the surgical center and have an anesthesiologist give you some sedation, that's fine, we could set that up. If you feel like you can tolerate it and you want to do it in the office, it's more convenient to do it in the office, you can do that too. It's patient preference. In the neck, the cervical spine, I do like to have people awake. I do give them a little bit of sedation in the surgical center, but there's more blood vessels and there's more structures in the neck, and it's a little bit more dangerous, and so I like to have people at least a little bit awake to answer some safety questions. That's my personal preference. There are other doctors that will put you completely to sleep for cervical spine, lumbar spine injections. Again, it's just personal, the doctor's preference as well. Does it hurt? Yeah, it's a needle. It's gonna hurt. It's a needle in the back, a needle pinch, doesn't feel great, but it's tolerable. And then as the medication goes in, like I said, you can feel that like weird pressure pain radiating down the limb, and that, it lasts for maybe 10, 15 seconds, but some people can't tolerate that. It's usually the young football players that can't tolerate it. And then how long until I get relief? So I think I talked about that. Usually within 24 to 48 hours, give it a full 2 weeks to feel the full effects. Do I get a series of 3? I think a lot of people have heard, oh yeah, I'm going to get 1, then the second, then the third. Again, that's the doctor's preference. I typically don't do mine that way. I do 1. I have the patient report back to me in about 2 weeks and let me know how they're doing. If they're better, we can do a second or a third, just get a cumulative response. If they're no better, it's unlikely that doing a second is going to do anything for you. And so we either want to change the type of injection that we're doing or change the location of the injection. So I typically don't do a series of 3. And how many can you get in a year safely? There's no good literature out there to tell us how long or how many you can get in a year. At the Rothman Institute, we adopted the rule of 3 to 4 in a year time frame. Now, if I have a cute 90-year-old little patient who's, the only thing that gives her relief is getting an injection every 2 months, well, guess what? I'm going to do it. Because at that point, at 90 years old, let's keep you comfortable. So, and then what percentage of people get relief? So it depends on what the underlying cause is. For spinal stenosis, epidural injections are hit or miss. I have some people that do fabulous. They come in once a year, they get a year's worth of relief, and then they're fine for the whole year. They come and see me, and then they're doing great. I have other people who get 2 weeks relief, and then their pain goes right back to baseline. That is not considered a successful injection. So I usually tell people for spinal stenosis patients, it's about a 60% chance that you will get long-term relief. Long-term relief is, 6 months to a year relief. The problem with spinal stenosis is you're not changing the underlying structure and the underlying problem. And so if you're not getting relief with the injections, then you may want to talk to a surgeon. Sometimes surgery is too complicated. Sometimes people have other, health problems where they can't do surgery. And at that point, maybe we just do injections periodically. So it's on an individual basis. If you have a herniated disc, either in the neck or the low back, about 75 to 80% of those people do get some relief. There was a study done where they looked at patients who had herniated discs, and They saw their pain at day 1, and then they saw their pain 5 years later. Regardless of what these people did, whether it was surgery, just sat there and did nothing, or got injections, in 5 years they all seemed to be doing the same. I don't have 5 years to wait to be out of pain. I don't know about you guys, but you know, that's why we do this stuff. We're trying to get things moving a little bit faster and get you feeling a little bit better. If at any point somebody starts developing weakness or problems, then we, with bowel or bladder or anything that seems more, you know, more neurologic in nature, I usually get them to the surgeon sooner rather than later. But when you have a disc herniation and you do the injection and you relieve the inflammation, eventually over time that disc can sort of reabsorb, or the nerves can get used to living in a smaller house, and so you get sort of permanent pain relief. So that's typical epidural injection stuff. Complications, I have to talk about this. Nerve damage, paralysis, infection, bleeding, headache, death. Has to talk about all of that stuff. About thousands of these get done every day in the United States, and we don't hear about these catastrophic things, but we have to tell you about it. I would say the most common adverse effect that I get is a headache, and that's even pretty rare. And the headache is usually from the steroid. So I think a couple years ago, maybe September 2012, you guys may have heard that scare with the fungal meningitis, and that was, you know, people died from that because the steroid was contaminated with the fungus. And so that's what we're talking about, the infections that can really be dangerous. When we talk about paralysis, the way people can get paralyzed from these injections is if you are inadvertently injecting into a blood vessel. If you inadvertently inject a steroid into a blood vessel, it can clog up that blood vessel, and then you no longer get excuse me, blood flow to the spinal cord or to the nerves. And that's how you can become paralyzed. How do we prevent that? Well, we do it under live x-ray guidance. You're injecting some contrast dye. If you see that there's no blood vessel there, then you're safe. We also do it by using a steroid that doesn't clump as easy. So there's different steroids on the market that you can use. I use ones that typically don't clump inside the blood vessels if I were to inadvertently inject in a blood vessel. And that can and I worry a little bit more about that. I'm always worried, so I always keep that in the back of my head, and I think that's why I haven't had any problems yet. Knock on wood. But in the neck, we worry about that a little bit more. There's a lot more blood vessels in the neck. There's the big artery called the vertebral artery, and that goes right to the neck and the brain. And I've heard some horrible stories where people will get injections in the neck, and young, healthy 40-year-old people, and they wind up dying. So you need to be careful. And when you're doing the injection, you need to be careful. And a little bit of paranoia is not a bad thing. So. Okay, so facet joint treatments. We talked a little bit about the little knuckle-like joints in the neck and in the back. And this is a picture of a facet joint that's irritated. There's a couple of ways to treat facet joints. We can inject the nerve that goes to the joint, and I'm going to show that on the next slide. Or we can inject inside the joint directly. We call that an interarticular injection. Now, if you remember, I said before, there's really no way to tell whether or not your pain is coming from the facet joints on physical exam. This is how you tell whether or not your pain is coming from facet joints. Patient comes in, I usually have them fill out a pain diary, meaning their pain is, 8 out of 10, it's in my back. And then they draw on the little person that I have there where their pain is. I inject them, I put some numbing medication, just numbing medication, lidocaine or marcaine, into the joint. And then I have them sit in the waiting room. I come back out and I talk to them about a half an hour and I say, how's your pain? And I already know when I come out, because if they're smiling, I know it helped them. If they're not smiling, I know they don't feel any better. So if they're feeling pretty good, and it's that quick, the lidocaine, the numbing medicine will work that quickly. I come out and people are like, oh my gosh, I feel amazing. I haven't felt like this in years. I feel great. Then I know that that's the joint that's causing the pain. And so the next step is we can bring them back and we can inject a little bit of steroid in that joint. This is not comprehensive of all of the procedures that are out there, but just sort of the most common ones and the ones I get questions about the most. So that's it. Any questions?
Can you burn the nerves that go through the femora down to the legs?
Good question. So he asked if you can burn the nerves that come out of the foramen, or the hole where the nerve comes out. You cannot burn those nerves. And the reason why is those nerves control motor function to the leg. So basically, controls the muscles. If you burn that, you're probably going to get chronic pain in the leg, and then you're going to get weakness, and you will not be happy.
The last thing that you showed, is that the same thing as a TENS machine?
No. TENS machine goes out on top of the skin. And this is actually an implantable device. You can't see it from the outside.
But it does it does a similar thing, does it? Not by interrupting the message from the nerve?
So this actually sits on the outside of the spinal cord and changes the signal within the spinal cord. The TENS unit usually allows it allows the muscles to contract and relax, and sometimes you get pain relief that way. But they are two totally separate things. But they both use a little electrical stimulation to help with pain relief.
The injection you do in your office, you said with steroid and lidocaine, and that can be a long-term effect?
So it depends. Typically people with spinal stenosis don't do great long-term. And so I will try it because sometimes, you know, we don't really have anything else. Or like I said, if they have other medical problems, that surgery wouldn't be helpful. Or let's say the surgery would be just too big of an operation. Then we have to do them periodically. But for the herniated discs, you know, that disc will eventually reabsorb over time. And so what we're really doing is just trying to give you some pain relief in that time frame where that disc is going to reabsorb. And so it can really give long-term relief in that
Same
respect.
injection you would do if you go to a surgical site. Same stuff you put in.
Exactly the same, yep.
Is that like cortisone?
Yep, cortisone, yep.
But
Exactly.
you see where you're going.
Yep, you see where you're going. And there's tons of different types of cortisone type steroids.
Okay.
And so that's what I was talking about when I said some of them clump in the blood vessels, some of them don't. So, but yeah, it's a cortisone.
Multiple problems along the disc, I imagine that would constitute multiple injections. True?
Depends. So not all discs that look like they're troublemakers on an MRI are in fact troublemakers. So when you're talking about doing an epidural injection, you want to do the injection where you think it will be most helpful. So I use the example of the L5 nerve root being pinched, and that'll give pain on the outside of the leg and outside of the calf. Let's say you had a problem at all the discs in your low back, but your symptoms were in the L5 distribution. I would do injection around the L5 nerve root. So you base it on the person's symptoms, not what you see on the MRI.
You had mentioned if you had symptoms, it would require immediate attention. But what is the process for that? You just go to an emergency room?
Yeah.
And you present
Well, if you're a
yourself?
Rothman patient, you go to the Jefferson emergency room and you tell them, I'm a Rothman patient, I want a Rothman doc to operate on me. But yeah, I mean, if you're not near Jefferson, you really need to get to the closest emergency room, ideally, so that, you know, it can get decompressed.
And what would those symptoms be that would require immediate attention?
So those symptoms are numbness and tingling into the groin region, meaning anywhere that you would sit on the saddle of a horse. We call it saddle anesthesia. Any of that area, if that were to become numb. That's usually associated with pain radiating down the leg that's getting worse, weakness, can sometimes have incontinence of the bowel or bladder. So I usually tell patients, listen, if you get numb in the groin region and you lose control of your bowel and bladder, don't even bother calling me. Get to the nearest emergency room and get somebody to check this out. Usually they'll do a workup or they'll do an MRI if they have access to an MRI machine. Otherwise they'll do a CAT scan, and then they'll call the neurosurgeon in or the orthopedic spine surgeon in to talk about doing a decompression. Decompression means they're going to get the pressure off the nerve.
Can you typically develop arthritis around any one of the discs in your back the way you can basically anywhere else in your body?
Mm-hmm. Yeah, but it doesn't necessarily cause pain. Just because you have degenerative changes in your disc doesn't mean that you have pain. I have so many patients that, you know, they have degenerative discs. Their spine looks terrible. I send them for some physical therapy. They come back, they're like, I'm doing fabulous. Great, see you later. So just because you have degenerative disc doesn't mean you're going to have pain. And so really, what do? You keep yourself strong, you keep yourself flexible, you know, try not to be, you know, gaining too much weight, use good body mechanics. All this stuff that you're going to learn in physical therapy is important, and can keep you from feeling the symptoms of a degenerative spine.
So if you do have a degenerative disc, if you do develop pain, it's probably for some other reason that you discussed here tonight. It's not necessarily that disc.
Right, and so you hit the nail right on the head, which is just because you have a degenerative disc doesn't mean that's the source of your pain. And that's why back pain and neck pain is so complex, because there are so many structures that really could be contributing to the pain. And it's very hard to say, oh yeah, this is it, this is it. So that's why we try and narrow it down with these test injections. There's a test called a discogram, which is a test that I was trained to do, but I will not do it because it's evil. And that can test whether or not the disc is painful. What I like to do is work backwards. I've tested everything else. I've tested the SI joint, I've tested the facet joints, I looked at the hip, I looked at everything. None of that helped. Well, you know what? Guess what? It's probably your degenerative disc now, because we've looked at everything else. And by process of elimination, that's probably the thing that's causing you pain. I could send you for a discogram, but I wouldn't if I liked you. A discogram is a procedure where you put the needle into the disc, you pressurize the disc with contrast dye, and see if the pain that you normally get is reproduced. It is terribly, terribly painful. And the only reason that I would order it, and I think in the 5 years that I've been at Rothman, I ordered it one time, and that was last week. And that's for a young guy, 25 years old. His back is pristine, looks perfect. There was one disc that looked abnormal. He would be a candidate for a fusion operation if I could prove to the surgeon that his pain was coming from that degenerative disc. I did the discogram. Sure enough, that's his exact pain. When we pressurized the disc, it reproduced his exact symptoms, and we knew that the degenerative disc was the problem. So he's going to go for an operation, and hopefully we'll do well. But otherwise, in people older than the age of 25, I'm going to work backwards. If I can't figure it out, I'm going to say it's probably that degenerative disc, and you're going to have to live with it.
When you inject somebody with a spinal stenosis, you're not going to change the stenosis.
Correct.
That's there.
Right.
You're correcting or treating inflammation.
Correct.
Yeah.
Yeah.
So that's short term.
It is short term. But like in the situation where, you know, it's somebody who can't have surgery and they need to have pain relief, or, you know, they're in their 90s and who's going to operate on a 90-year-old, sometimes, you know, it's beneficial to do it.
Sure.
And if somebody's getting 3 to 4 months relief out of it with spinal stenosis, and there's no, you know, they're really not a candidate for surgery, to me, that's worth it.
Okay.
So that's why we would still, those are some of the reasons in my head that I would do it for spinal stenosis.
When you fuse the spine, how much mobility does the patient lose?
I mean, that's certainly a question for the surgeon, but not a lot. Cervical spine, at least in the neck, you can fuse a couple of levels and still get pretty significant
What
motion
about
in your neck.
lower
Low back,
vertebrae?
I don't see a whole lot of decrease in motion either. What happens though with fusion is you start getting motion at other places, so you'll start getting more motion at your SI joints than you normally would, and so SI joints can then become a problem after fusion. I mean, you can start to have breakdown of the disc above the level of the fusion. So.
With the epidural injection, you mentioned about how long it would take for pain relief. How long would it be before being able to resume your full activities, you know, including sports and whatever?
It just depends on your tolerance. What I normally tell people is, now I normally have people in physical therapy in conjunction with doing these injections. And so I usually will hopefully quiet symptoms down, do the physical therapy, and I really like people to work with their therapist to get back to that level of activity that they want to be to. So, not a perfect answer, but it's really slow progression towards that goal.
Two-part. What are the detrimental effects of epidurals 3 to 4 times a year? And then if you continue on that course for another 2 or 3 years, is it possible to continue, and what would be the effects?
Okay, so it was a 2-part question. The first part was, what are the detrimental effects for getting epidural injections multiple times a year for several years in a row? And then I'll have you ask me the second question in a second. So exposing anybody to steroids multiple times in a year can cause some problems with, this is either oral steroids or injected steroids. It can cause problems with blood sugar. People who are diabetic, we need to worry about their blood sugar may be elevating after a steroid injection. Typically doesn't elevate that much with a steroid injection. It's more with pills that your blood sugar will get high, but I worry about it anyway. And then osteoporosis, so thinning of the bones, can occur with prolonged or continuous exposure to steroids. If you're getting injections in the joints, like the hips, the shoulder, the knee, they talk about breaking down some of the ligaments, breaking down some of the tendons, and it becoming a problem. We haven't really found that it's much of a problem in the spine. There is some evidence out there to suggest that the sac where the nerves are contained, the dura, can get a little bit thin. Then there was some literature to suggest that that's not true. And the only reason that that would be a problem is if then you went on to surgery, you could get like a dural tear. But really it's the diabetes and the osteoporosis that I worry the most about.
You said that when you get the injection, it could take about 2 weeks.
To feel the full effect, yeah. That's not typical though.
Can
that
you
should be fair.
feel perfect at that time, which I did that night, and
Uh-huh.
the next day, and then it went right back
Yes.
to where I was?
So that is not a successful injection, and I would not recommend doing another one at that level. So I would either see if there's something else that we can do, another level to inject, or another structure to inject. So.
There's a procedure where they take your blood and they run it through the centrifuge and they re-inject it. Is that something that you would use for spine or neck?
Not yet. That's called PRP, plasma-rich platelet.
Yeah.
So they usually are using it for like tendinosis or tendinitis in like the limbs. Some people are injecting it into the SI joint. I don't know what the literature says about it. There's nothing in the spinal canal that anybody's doing yet. At some point they're probably going to do something with injecting it into the discs, but I haven't heard anything about that yet.
How about Simvis shots?
So Simvisc shots sometimes into the joints, never into the spinal canal. Anybody else?
So, numbness down the arm, like almost constantly, is that something just, you're saying that it's still elective to have something done? It will go away by itself, I guess is one thing.
So it may or may not go away by itself. It depends on what the underlying reason for the numbness is.
So it could be a more dangerous situation.
I don't worry too much about numbness actually, as long as it's stable.
And no strength, like that kind of thing, is that a sign?
When
that-
people start having weakness, I start to worry a little bit more. Constant numbness that is stable and not changing, I don't worry about. Numbness that's getting progressively worse and started off in the thumb and now it's spread to the whole hand, and now it's going up the arm, that I'm going to worry a little bit about because I want to, sounds like there's a dynamic process going on and I want to investigate it a little further. Numbness that stays in these two fingers and it's been there for the last 4 years and it doesn't really bother me, I don't worry too much about. But weakness I do worry about.
Is it 3 individual shots a year or 3 series of shots?
3 to 4 individual shots.
Okay.
Now, sometimes we can skirt around that by saying, sometimes I'll do a shot on either side of the spine, which to you sounds like 2 shots, but we count it as 1. So it's basically 3 to 4 individual sessions of getting an injection in one particular area. Sometimes we'll do 3 in the back or 3 in the neck. So we'll break the different parts of the spine out.
So I had 2 up through the sacrum,
Okay.
which didn't seem to do anything.
Okay.
And then, I don't know, a month later, they came in at L4
Okay.
from both sides,
Okay.
and that seemed to work.
Okay. So that's good. So maybe they were closer to the area where the nerves were being irritated.
But that was over maybe a 2-month period.
Okay. That's fine
That's
that they did
good?
the 2 with, yeah, that's absolutely fine. Yeah, we'll do that.
Which part of the back makes you have like the restless leg tingling?
So without getting too complex, you can get numbness and tingling or problems in the legs from any part of the spine. Typically comes from the low back, but not necessarily. I've had some people come in and their low back looks perfectly fine, but they have some symptoms in their legs. I wind up getting an MRI of their neck, and they have actually pretty significant narrowing of the canal where the spinal cord travels. Take care of that, their symptoms in their legs go away. But to simply answer the question, it's usually the low back.
Okay, thank you very much.
Thank
Marino.
you.
Yes, thank you.
Very-